Cardiovascular pathology, heart failure. All right, heart failure. Heart failure is such an interesting topic. I love to talk about it. So first and foremost, how can we define heart failure? There's no clear-cut, concise definition that I can give you right now, but what I want you to know is this. Mainly look for a decrease in cardiac output and an increase in total peripheral resistance, okay? There are high output heart failure pathologies, but for majority of the heart failures, you're going to see low output, so decreased cardiac output with an increase in TPR, okay? So what does it mean? Heart failure just means that the pump is dysfunctional. Our heart is a pump, and it pumps blood throughout our body, and so when we have a dysfunction to that pump, to the heart, okay, then we're going to be known to be in heart failure, okay? And there's two types of heart failure that we have to be able to recognize. The first one is HFrEF, and the second one is HFpEF. HFrEF, H-F-R-E-F, is heart failure with reduced ejection fraction, okay? So that means that we are unable to preserve, okay, the amount of blood that should be pumped out, okay? So we have a decreased ejection fraction. HFpEF, okay, is going to be heart failure with preserved ejection fraction. So we have normal ejection fraction, normal amount of blood that's being pumped out. But that means that the pump, there's something else wrong with it, okay? So with HFrEF, reduced ejection fraction, it mainly is associated with dilated cardiomyopathy. Because what do we say about dilated cardiomyopathy? Is that the pump, okay, it's systolic dysfunction. We can't pump hard enough. We can't squeeze hard enough. It's systole that's a problem. Okay, we can't get the blood out, and hence that's why we see reduced ejection fraction if it progresses to heart failure, okay? With diastolic dysfunction, right, which we saw with hypertrophic cardiomyopathy, we're going to get preserved ejection fraction if we have heart failure, right? Because it's a problem with relaxing the heart in hypertrophic cardiomyopathy, not squeezing. So the blood that's being pumped out is still preserved. Okay, we still have normal amount being pumped out. So I hope that makes sense. That's the first thing that we have to kind of differentiate. So systolic dysfunction, usually associated with dilated cardiomyopathy, can progress to heart failure with reduced ejection fraction. Okay, then there's diastolic dysfunction, secondary mainly to hypertrophic cardiomyopathy, that can progress to heart failure with preserved ejection fraction, okay? That's what we need to know. Now, there can be right-sided heart failure and left-sided heart failure. So I just gave you two types, what I was talking about earlier, systolic dysfunction, diastolic dysfunction, that HFrEF and HFpEF are two separate types of left-sided dysfunction, right? But there could be right-sided heart failure. Okay, and the most common cause of right-sided heart failure is left-sided heart failure, right? The blood gets so backed up from the left side of the heart, it goes through the lungs, and then the blood still can't get through, and it gets backed up all the way to the right side, and that right side is unable to squeeze all that blood forward, and it starts to fail. And so the most common cause of right-sided heart failure is left-sided heart failure. However, there is a specific type of right-sided heart failure where we have no left-sided heart failure. So an isolated right-sided heart failure is known as cor pulmonale. And they put pulmonale, cor meaning heart, pulmonale meaning lungs. Okay, so they're telling you that it's a problem with the lungs. Okay, so if there's a problem with the lungs, you're going to see isolated right-sided heart failure with no left-sided heart failure issues. But once again, the most common cause of right-sided heart failure is that left-sided heart failure. All right, so what do we need? What do we see? So with the left-sided heart failure, we're going to see shortness of breath when they lie down. Okay, because that blood, okay, is kind of just filling up and backing up all the way into the lungs. Because we know our cardiovascular system, it's a closed system, okay? So if we can't push forward out of the heart, it's going to back up, okay, starting at the left ventricle, back up into the left atrium, and it's going to back up further up into the lungs. And it's going to stay in the lungs, okay? And while in the lungs, it's going to cause pulmonary edema, okay, because we have increased pressure now in those pulmonary vessels. And that increase in pressure in those pulmonary vessels are going to lead to a leakage out of fluid into the lungs. And so when they lay down, they have essentially fluid layering all of their lungs, and they get orthopnea, shortness of breath when supine, okay? Now, they can also get paroxysmal nocturnal dyspnea, same thing. They get breathlessness awakening from sleep because, once again, they feel like they're drowning. And lastly is that pulmonary edema, okay? Because we have all of that stuff, right? We have that transudation of fluid, okay, which is characterized with a decreased protein in LDH, but it's transudation of that fluid into the lungs outside of the vasculature. Okay, so that's left-sided heart failure. It's backing up into the lungs, okay, causing that orthopnea, causing that breathlessness awakening, okay, and that pulmonary edema. Patients will present with, doc, I can't fall asleep unless I'm sleeping on the recliner. Hey, doc, I'm sleeping with 4 to 5 pillows a night to prop me up. Okay, those are signs. They're telling you that they can't lay on their back and sleep. And that's a hint telling you that there's some type of left-sided heart failure that's backing up into the lungs. Okay? Lastly, with pulmonary edema, what they like to ask you is heart failure cells. Okay? And these are just hemosiderin-laden macrophages within the lungs. Okay? So in the lungs, right, we have our own immune system once again, right? So the macrophages in the lungs are going to sense invaders, right? So if we have pulmonary edema, we get these red blood cells that start to be able to squeeze out of the vasculature and get into the lung parenchyma. So what does it do? Our macrophages start to eat these red blood cells, okay, and starts to eat the transudation of the fluid that's coming out of this vasculature from the heart. And they become laden with hemosiderin, okay? And hemosiderin-laden macrophages just means that since they're eating the red blood cells, there's going to be iron, because we have iron in our red blood cells. So once the macrophages eat them, they're going to have iron in those macrophages. So those are hemosiderin-laden macrophages, also known as heart failure cells, okay? So keep an eye out for those. Look up what they look like online for histology. It's just like these macrophages with like brownish stuff in them or like reddish stuff in them, okay? Next is right-sided heart failure, right? So we already said cor pulmonale. It could be due to something wrong with the lungs and backing up into the heart, or it could be mainly due to the left-sided heart failure that backs up all the way through the lungs and then goes further, backs up into the right ventricle, then right atrium, and then you get right-sided heart failure, okay? And when we have right-sided heart failure, we're going to have different symptoms, okay? And the symptoms that we're going to see is congestive hepatomegaly. So guess what? When we have a backup in the system, okay, so all the blood that's draining from the liver, okay, the blood's going to go through the hepatic vein, and the hepatic vein is going to drain through the IVC, okay, the inferior vena cava. And that inferior vena cava, as we know, dumps right into the right atrium. Well, guess what? If the right atrium is backed up due to left-sided heart failure leading to right-sided heart failure, it's going to back up. So no blood's going to move forward. So you have all this blood just sitting there, and so that means we can't get new blood in. So that blood backs up even further through the IVC, and it causes a congestion at the liver. Okay, and this is known as congestive hepatomegaly. And so patients will get nutmeg liver. So look up on gross examination, you're going to see a nutmeg liver. And so it's just this congested liver, and make sure you look up a photo of it. And what they see is that when I press on the liver, okay, that blood, instead of going into the heart, it's going to pass the heart because it can't get through, and it's going to go up into the JVP, and it's going to cause an increase in JVP. So you'll see an increase in JVP as well, right? So you'll have jugular venous distension in patients that have right-sided heart failure as well, okay? And lastly, we're going to see peripheral edema. So with left-sided heart failure, we saw that we had pulmonary edema for the lungs, right? Because that fluid is just sitting in that blood vessels, and it causes an increase in hydrostatic pressure. Same mechanism here, but we're just at a different location. Since we're on the right side of the body, okay, all that blood doesn't back up into the lungs, it backs up into the system, the systemic circulation. So it's going to back up throughout all of my body, the rest of my veins, and so all of that blood just pools in the bottom of my legs, okay? And I get peripheral edema because of the increase in the hydrostatic pressure. And we get that fluid transudation seen there, okay? And that's all due to the fact that we have an increase in venous pressure. And the reason we have increase in venous pressure is because no blood can move forward, okay? So what occurs? Okay, so I've told you the symptoms, okay? And it's, by the way, it's very common to see only left-sided heart failure symptoms, right? Because that means that we haven't backed up all the way to the right side. And if you see both left-sided heart failure and right-sided heart failure symptoms, so the lungs and the systemic systems are involved, then you know that it's left-sided heart failure, right? So whenever the lungs are involved, you know the left-sided is involved at all times, okay? However, if the lungs are not involved, if you don't hear any crackles on examination, if they don't tell you that there's any rales or pulmonary edema, then you know that, hey, it might not be left-sided heart failure. They might be just focusing on right-sided heart failure, okay? So what happens? If I have heart failure, that means I'm not getting blood to the proper organs, okay? That means that there's no oxygen getting to the organs. So what happens? I have a decrease in that cardiac output, right? That's the initial start of it. And so since I have a decrease in cardiac output, my body's like, hey, I need more blood to come to me. So it's going to increase its sympathetic tone by using catecholamines, okay? So the sympathetic nervous system is going to kick in, and it's going to constrict our blood vessels. Now you might think, hey, if there's a drop in cardiac output, why would I want to constrict my blood vessels? Well, think about it this way. If I cover my finger with the end of the hose, it brings more pressure to the water and it shoots out. That's the same concept before our organs. Our organs are like, whoa, we need more pressure. We need more blood. We're going to constrict. We're going to have increase in resistance so that more blood flow comes to us. Does that make sense? So that's the first thing that occurs. The sympathetic tone increases. We get vasoconstriction to the vital organs, okay? Now, that's immediately going to occur, first off. Then a couple days later, we have the renin-angiotensin-aldosterone syndrome or system kick in, the RAS system, okay? And what RAS does, right? So the kidneys are one of those vital organs that aren't being perfused well because of the drop in cardiac output. So it senses this decrease in perfusion, as we discussed. And what it does is that, hey, I'm going to release renin. And renin's going to go and it's going to activate angiotensin, and angiotensin is going to go and activate aldosterone, okay? And doing a bunch of things down the line. And what we care about right now for the cardiovascular system is that when it does that, it's going to cause a bunch of fluid to be retained in our body. We're no longer going to be peeing out anything because it senses that there's low blood pressure. Well, guess what? The amount of blood in our system is fine. It just can't get to the organs. So we actually have an increased amount of fluid in our body, increased amount of blood in our body that can't get to our organs. So the renal system is actually doing something worse. It's harming our body by activating the RAS system because now there's more fluid in circulation that still can't get back, okay? That still can't be pumped out. So it's going to cause even more backup, even more edema, okay? And it's called a fluid overload state. Does that make sense, everyone? I hope that makes sense. If you have any questions on it, it's a very key concept to understanding what's going on with heart failure. The RAS system causes an increase in circulating volume, but that volume cannot be pumped out by the heart because you have heart failure. So it's like a vicious cycle that the heart is like, oh, I can't pump out anything. There's no cardiac output. I can't give any of the vital organs anything. And so the vital organs are like, wait, where's our blood? And so the renal system's like, oh, maybe the blood pressure is low. I'm going to add more fluid. I'm going to retain it and make sure I don't pee it out. And that more fluid just gets lost via like edema and it just is pooling there, okay? So I hope that makes sense to everyone. Now, lastly, the marker in which we need to look for is BNP, okay? BNP and ANP are released in response to ventricular stretch for BNP and atrial stretch for ANP. So when the atria is being stretched too much, it will release this peptide known as ANP. And when the ventricle is being stretched too much, it will release a peptide known as BNP. And that's in response to too much fluid, fluid overload state like heart failure. And this opposes RAS system. It's our body's ability to oppose RAS. So if you see a very high level of BNP, you know that a patient most likely has heart failure. Okay, there are other causes that cause increased BNP, but this is one of the things that you have to know. Increased BNP is something that we look for heart failure. All right. So overall, make sure you understand this. And lastly, the question is, how do we treat it? There are multiple types of drugs that decrease mortality. Okay, so we're going to give these patients drugs that decrease mortality. And there's a list that is very, very good for them. And I'll go over them in the pharmacology section. But I just want to make sure that you guys know them here and now so that we don't forget them. So the first one is ACE inhibitors, ARBs, angiotensin receptor neprilysin inhibitors, beta blockers. Okay, these all decrease mortality. Hydralazine with nitrate therapy also decreases mortality. Okay. When we use loop and thiazide diuretics, those are mainly for symptomatic relief. And then finally, our SGLT2 inhibitors are also going to decrease mortality. All right. So I'll cover the drugs again that decrease mortality, but I just wanted to say it one time really quickly here, just so that you know it. But that's all for heart failure. If you have any questions, please let me know.